Hello again, everyone, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and most of us have had heartburn after a big meal. But for some people, reflux, it's not just an occasional thing. It's something that affects their sleep, their diet, their daily routine. And I think while a lot of folks turn to things like antacids or over-the-counter pills, reflux can actually go a lot deeper. And we've got kind of a unique take on it today with two doctors who deal with this specifically. I want to welcome Dr. Pial Hope, who is in today, and Dr. Ali Zakaria to talk about teamwork when it comes to this topic specifically. A lot of people, when this subject comes up, they think, look, I'm going to pop a Tums, I'm going to be fine, but I woke up the next day and it's back again. I go to bed at night, it's still there. This isn't getting better with just over-the-counter medication. What and when does reflux become something more serious that they need to come to you two guys? Let's start with you, Dr. Zakaria.
Yeah, of course. Thanks for having us again.
You bet.
I think this is one of the most common topics that a lot of people they suffer with, and up to 30% of people, like three of us here. Definitely one of us has it. I know who that is. So yeah, it's a very common topic. And again, some people they just have mild reflux, a heartburn sensation, burning sensation in the mid chest, or they feel like food is coming up after they finish their meal. So those are the two most common kind of presentation, either heartburn or regurgitation. And some people will actually take Tums or Gaviscon or some kind of medication or acid suppression medication in terms of H2 blockers or PPI or proton pump inhibitors, and they will feel that their heartburn is absolutely controlled. I don't have heartburn. That works for me. But then the regurgitation is not. So they feel like, I bent down to tie my shoe and the whole food is up. Now like the food is in my mouth, or I, went to bed and, I couldn't sleep because I'm almost choked on the meal that I just finished. So those are the kind of things that can actually affect the patient's life. They can, affect their daily living because they're miserable with simple things that they do every day. They go to bed. Everyone's going to go to bed, so they are having symptoms because they go to bed. Some people, their heartburn is not controlled because even with the medication, some patients, they still have significant heartburn symptoms. The most important question that, when I see patient in my office is to ask myself, do they really have reflux? And if they do have reflux, which type of reflux are we dealing with? Do we have something called erosive gastroesophageal reflux disease, which means that I go in and they have severe reflux changes damaging the esophagus? Do they have a non-erosive gastroesophageal reflux? They have reflux, but that's not causing any damage to the esophagus. Or do they have what we call it hypersensitivity or functional heartburn? Maybe they are just sensitive. We are in 2025. Sensitive is very subjective,
it's
right?
Everywhere.
So that's the same thing, right? If they have baseline anxiety or something like that, then maybe it's the brain-gut kind of communication nerve system is getting affected.
Can stress cause heartburn?
Yeah, those people with anxiety and stress, they have maybe just a reflux episode that is normal. Everyone should have reflux, or what we call a transient lower esophageal sphincter relaxation. But those who are sensitive, it's just going to be worse.
Okay.
So the treatment of that is different. So we always have to understand where the patient is coming from, which category we should put them in, and then take it from there.
So when does it become an issue, Dr. Hope, where you have to step in?
Sure, absolutely. So just to, all that he was saying, that's just a small glimpse into how complicated this problem actually is. It's much more complicated than just I get a little burning in my chest, because you might feel that way or someone might have that symptom, but the cause of that could be extremely nuanced. And I'll just second his point. It's extremely important to get the right diagnosis so we can categorize them in the right kind of category and intervene accordingly. You could do the wrong operation or you could do the wrong type of medication if you have the wrong diagnosis. So when do I get involved? Well, there are various structural problems that could exacerbate or lead to reflux disease. And there are some natural anti-reflux mechanisms that we all have as human beings. And each of those anti-reflux mechanisms could be disrupted if you have one of these problems. So, for example, the most common problem is something called a hiatal hernia. A hiatal hernia is a type of hernia that you can't really see with your eyes. It's not like a lump on the belly wall or the groin with those types of hernias. This is a hernia whereby the stomach will herniate through or protrude through a natural aperture in the middle of your diaphragm muscles as they coalesce in the midline. And that can essentially cause a lot of these symptoms. So it's important to find out, not everyone with a hiatal hernia, however, will necessarily have pathological GERD or something that requires a surgery to fix. But the natural opening just becomes loose or lax, and it allows for the herniation of the stomach, and there's various degrees that this can happen. So you can have a very tiny one, and the size of a hernia doesn't necessarily dictate its severity. Or you could have a massive one whereby your whole stomach, in addition to other organs, are in your chest cavity. So there's different types of symptoms that can arise due to that, though.
Reflux, like we've talked about, can be caused by a lot of different things, too. Stress, we've talked about that. Weight, the hernia that you're talking about. How do you guys get together and figure that out, though? How does that begin?
So let me just correct this misunderstanding.
Yeah.
Actually, reflux is not caused by all of that.
Right.
Reflux is purely an anatomical abnormality where the gastroesophageal junction area, or that apparatus that Dr. Hope just described, is failing. So that is the cause of reflux.
That's the cause. Okay.
All other things are exacerbating factors that can lead to worsening symptoms. So let's just put that together, because if you remove all of the above and the apparatus is not functioning, you haven't fixed reflux. You just kind of mask it. Yeah. And that's what medication does. The medication will suppress the acidity, but it's not going to fix the problem. The problem is anatomic. So the anatomy is failed. Either the muscle that is a valve between the esophagus and the stomach is relaxed, is not working. There's a hiatal hernia where the diaphragm is actually keeping things in place. That's failing, and there's a hiatal hernia. And then the length of the esophagus, there's a intra-abdominal segment of the esophagus that should be in the abdomen to help with that. That's also not there. So when those three mechanisms fail, then you will end up having pathologic reflux.
So you said everybody gets reflux, or we should all naturally get it occasionally.
Yeah.
And if you get it somewhat consistently or not, and the medication is working, why would they come in and see you then at that point, right?
Yeah,
why, if the medicine works, but they have that failure?
Here's the thing. Some people will say that I don't want to put a 40-year, auto-renewal on some of my prescriptions.
Right.
I am 35 or 32 or 25, and I have pathologic reflux that if I stop taking a medication one day, I'm miserable. And I'm not going to put a renewal for 40 years or 50 years, or people are living to their 90s now.
Yeah.
So I don't want to put that in my, plans of life. So they don't want to be on medication for, a long period of time. 2, their heartburn is controlled, but their regurgitation is not controlled. They're just having this choking feeling. Medication is not going to fix that.
Right.
Or I will give you a story at the end. It's a very kind of successful story at the end of the kind of talk, just to tell you how we also select certain patients that is quite rare, but how they come in and we provide this new technology for them. So those are the patients that we say, okay, well, it's not for everyone. So surgery is not meant for everyone, but for certain patients who prefer not to be on medication for a long period of time, for certain patients that we cannot actually use those medications, I'm going to give the example at the end, or patients that their heartburn is controlled but their regurgitation is not controlled, then you have to fix the anatomy to get them there.
Okay, well, let's talk about, because you used the advanced endoscopy. That's something you specialize in. So what kinds of less invasive treatments do you start with before we have to go to Dr. Hope?
Yeah, so the way that we cooperate with Dr. Hope is basically the patient comes to my clinic, we confirm that they have reflux, they have, he's a good candidate for anti-reflux intervention. The next thing, I look at the patient as a whole. We don't just tell them go to surgery. We start with a lifestyle modification, avoid trigger food, lose weight, look at their BMI. I always bring weight every time that we talk about any topic, and you can kind of rely to that. Because weight is culprit in so many of those things. Mm-hmm. So
It's a risk factor.
It is a risk factor. So if I start with a weight loss, weight management, don't eat and go to bed, last meal should be 3 hours before the bedtime, theoretical positioning, sleep on the left lateral, that can help. Raise the head of the bed by a wedge or something, that can also help. And if that all doesn't work, then we go into smoking cessation, of course.
That's
smoking cessation.
Stopping NSAID medication. Certain medications can cause the problem, like over-the-counter pain medications, for example, like ibuprofen, Aleve. I mean, those can cause more peptic ulcer diseases, for example. But those are all just part of the
lifestyle changes.
Modifiable risk factors.
So if they start with the lifestyle and then I start them on a medication and then we get to the point that, well, you are a good candidate for the surgical intervention, then we communicate with Dr. Hope. And the starting point is with an upper endoscopy for proper evaluation. We'll see the anatomy, the esophagus, if there is a hiatal hernia or not, and if there is a reflux changes that needs to heal before we do an intervention. We look at motility to make sure that the esophagus is actually contracting properly and there is no motility abnormality. There is no eosinophilic esophagitis, that topic that Dr. Turk had presented recently that can mimic this.
Is that the EE, is that right?
EOE, yes.
EOE,
yes. So there's no motility abnormality like achalasia, which is a very big problem that Dr. Hope tried to mention early on, is that some people are misdiagnosed. They come with regurgitation, but the problem is not the muscle being lax, it's actually the muscle being super tight because food is not coming through it, and they have regurgitation because the food is not going through. And if those end up having anti-reflux, they will be miserable.
Yeah, you're actually worsening the problem.
You're making them worse. So you have to be very particular about how do you do that. And we have all the new technologies that we do where I can do a one-stop shop. I can test motility. I can test acid exposure by a Bravo capsule or a pH monitoring capsule that can sense the acid exposure to that area with objective data. Look for hypersensitivity, look for anatomy, and then decide what's next.
Okay. Yeah. Well, what were you going to add to that, Dr. Hope?
Well, no, a lot of people have not gastroesophageal reflux, but rather esophageal reflux. So that sometimes will present similarly, but it's not coming from the stomach to the esophagus, but rather it either hasn't transited from the esophagus into the stomach yet, and they just feel that sitting there. That's something that achalasia patients will feel. But also achalasia patients sometimes have insensate esophagus, so they don't really sense how bad their reflux is because they just sometimes don't. It's like almost like tending towards burning out in terms of sensation. So we have kind of like digestive diseases it needs a comprehensive kind of multidisciplinary evaluation. It's so easy to just say, oh, you have some heartburn, here's some medications, which for the majority of people, intermittent acid suppression therapy is, just chronic acid suppression therapy may be appropriate, but it needs to be just a good nuanced discussion, and the patients should be well informed of all the different options and about the risks and benefits of each of those options. One thing that's I think special about our kind of work relationship and collaboration is that, traditionally GI and surgery kind of work in silos. They work patients up independently. There's some cross referrals. I found this. Okay, here, now take over. But we work very collaboratively, and this is kind of really opened up. And personally, anyway, I've learned a ton from Dr. Zakaria about how the GI physiology and some of the ways that GI physicians will approach these types of problems. And I think I've grown as a surgeon by collaborating with a GI physician. And that's what's special, is that having two like overarchingly similar expertise, but also extremely, varied in our experiences and our approaches. And I think when we bring that together, it really has helped blossom this program and ultimately benefited the patients.
As far as you know, is this a relatively new thing that's happening in medicine and in your particular disciplines?
No.
Or is it?
The transoral fundoplication, which is the TIF, that's like the kid in the block, has been created back 15 years ago.
Okay.
There was TIF 1.0. That was not the super easy, not the super kind of,
It was a clunky device.
There was a difficult device. The data was not really good about it. People just tried it, and then they just got away from it. And then they got the upgraded form 2.0, and that was significant improvement. And then I think I really truly agree with the statement, because the team who created that was a collaboration between a surgeon and endoscopist to understand the physiology of that system, the esophagus and the stomach. We all thought that the reflux is just because of a sphincter, a muscle. It's relaxed, just put it back. No, it's actually more complex than that. So when they understood that all together, they put that new technology and device, and they said, that's the way to go. We will have a device that will lengthen the intra-abdominal segment of the esophagus. It will cause a wrap around the esophagus, the stomach wrap around the esophagus in the same way that we should have it anatomically or naturally, and then fuse that area with certain fasteners and have it as a wrap, tight enough to prevent reflux, but not enough to cause difficulty swallowing, failure to burp, all the side effects from the gold standard traditional surgical, purely surgical fundoplication.
I am so surprised at how nuanced this is from you just take some Tums and you're going to be fine.
Yeah. No, we changed the whole game with the new there is, of course, so many anti-reflux interventions from purely surgical to purely endoscopic. But I think from what we have learned from so many other, techniques and technologies, from, magnet augmentation device, which is just a device around the esophagus that opens and closes. We found that this is the most physiologic way of returning the anti-reflux mechanism that we had before it got disrupted. We're still in the premature area of just knowing what's going on. We have to study that for many, many years before we can say that, yes, that's the way to go. But so far, the data is pretty kind of promising. But I want to go back. So the patient, when I evaluate the patient, if they don't have hernia, then they can go right away for the transoral fundoplication. And it's literally, I go through their mouth, wrap the esophagus around, the stomach around the esophagus, pull the device out, and that's it. There's no surgical intervention. If I see hernia, then the device is technically approved up to a 2 centimeter hiatal hernia. If the hernia is almost an inch in size, then you can still do it. Above 2 centimeter, it's better to fix the hernia because you're not going to get as good of a result as if. So a lot of people, they don't really spend enough time to kind of evaluate the endoscopy well to look for a hernia. So they would say no hernia, and then the patient will get the procedure and they come back with symptoms because they never kind of evaluated it. I think the trust and the relationship that we built, same thing is that I learned the surgical aspect from him. I went to the OR multiple times and I saw that how he closes the hiatal apparatus, what is the size that we really want to get the best where there is no difficulty swallowing at the same time the patient is improving. So if I see a hiatal hernia, it's definitely a consult for him where he will evaluate the patient. We complement each other. If there's anything missing, we will just put that together. We'll have all the workup from endoscopy, acid, testing, motility testing, imaging studies, barium swallows, surgical fitness, all of these kind of things, no contraindication. Sometimes we had so many patients that, I'm lucky that he's both a foregut and bariatric surgeon, right? So I get a patient who BMI is more than 35, which is by criteria from the device company is contraindication for the TIF procedure. Then they go there, they can benefit from 2-in-1. Weight loss surgery and anti-reflux surgery. So they might just go into for 2-in-1. So they get both.
Right.
So that's why the combination had given the community and the patients the best, I think, solution for their problem that we can offer.
Well, and it seems like, Dr. Zakaria, you and I were talking a little bit about just new technologies. And of course, Dr. Hope, you are one of the best here when it comes to surgical robots, right? We did a whole podcast with you on that, and that has to be exciting as this technology continues to grow. That these surgical robots are able to step in and help. Has it made a big difference in what you specifically are doing?
Absolutely. I think there are a few procedures where I would say, hands down, robotic-assisted surgery for those procedures are superior than any other modality that exists today. And foregut surgery, specifically hiatal hernia surgery, is one of those procedures. Really? Yeah. And you just can't get the same level of high-definition visualization, stability, the reach that you can get through a transdiaphragmatic approach, meaning you're getting into the chest, but through the abdomen, through the diaphragm, is unparalleled. And the dexterity, which allows for more controlled movements, less tissue trauma, faster time to recovery, faster return to activities of daily living. So it's really I wouldn't consider doing this procedure any other way, really.
Does it surprise you, the speed and what you see coming in this technology?
Well, I mean, the last robotic system took, more than 10 years to come up with the next iteration.
And this latest one is like, there it is.
Yeah, exactly. So, the speed at which certain other technological advances happen seem to be faster, but I think it's because it's so complex when it comes to medical care. But I wouldn't be surprised if they had an endoscopic robot coming out.
There is actually.
So,
It is.
Well, we were talking about that, weren't we?
That's right.
And
Okay.
there's other places that they use it for kind of research purposes nowadays. And I know the physician who's actually leading that technology.
Right.
But it's not available for everyone. And
Right.
I think it's the way to go more. It's just going to enhance amount, as you said, like for you, when you will access areas that you cannot access. Same thing with endoscopy.
Right.
You'll have multiple arms that will make, endoscopy something a dissection at 25 minutes instead of 4-hour procedures. So.
Right.
That's what has really been so amazing for me in this field and the technology is how quickly you can almost have same day surgeries for these where people are coming in the morning and they're leaving by the early afternoon.
I mean, we do that.
And you guys do that all the time.
We don't admit patients for these types of
patient
procedures.
are doing fine,
and they're having major surgery. I mean, don't be fooled by the tiny little incisions. I mean, this is major surgery around major structures with potential risks of major complications, but they do extremely well and they go home the same day.
And their recovery is actually not that bad, to be honest. I mean, they just have to follow certain kind of medication for a few days, antibiotics for a few days, acid suppression medication for a 4-week, and then the post-surgical weight kind of recommendation for a certain amount of weight for certain days, and the food is the most kind of thing. And we had agreed that we're going to get our kind of protocol for 6 weeks, 2 weeks, 2 weeks, 2 weeks, and we advance the food as they go to make sure that they will actually get the benefit from the procedure. We're not trying to torture them. And that's why I actually keep telling people, they sometimes have the reflux and they hate to come and see physicians because they will ban me from doing, pizza or... No, I'm not going to take, Taco Tuesday from you.
Yeah.
Still, Taco Tuesday is good, but I want to make sure that,
that you can do it without
symptoms, without being miserable.
Right.
Yeah, we're not in that
love
business.
Tuesday and hate Wednesday. I mean, Wednesday is a good day as well.
Still
Every
good for
day.
tacos on Wednesday.
Every day should be good.
After listening to all of this, though, I mean, you've said a lot of things that I can hear or I can envision patients that maybe have these conditions thinking, God, this is really overwhelming. I got to go see somebody like Dr. Zakaria first, and then I might have to go see Dr. Hope. How do you navigate with those patients that might feel like this is just it's just too much? I'll keep taking the omeprazole or whatever, and I'll be okay.
I will tell you, I have so many stories to tell. I mean, we've done so many patients that we have great stories to share. People are driving hundreds of miles to come and see us.
Right, all over.
So it's not like
states.
living next door and they're bothered to come to see a visit.
Right.
Visits. People are driving 3 hours to come and see us. So what we do for those patients, we try to coordinate as much as we can because we share the same office, right? I mean, not the same office, but the same building, where both our offices in the same area or the same kind of area, and sometimes we coordinate between our team that, hey, this patient is going to come in and do this procedure today. If you can see her the same day and get whatever you need to get in the same day. So the patient will have less amount of driving. They will come in for a full day where they get their images, endoscopy, visit with the crew home, and they go home. So they get 3 procedures off the list of things that we need to do. I start doing the motility study intra-procedural called flip panometry with the new technology, with the new classification that we use. So now I can do the endoscopy, the motility at the same time. They can see Dr. Hope. They get their answer. We get the endoscopy results. You're good to go.
Right.
So we trying to coordinate as much as we can. We are already booking our day for the procedure way in advance to kind of make sure that we add more patients to get them at the same time. That's for, trying to make it easier for patients. Before I forget, one of the cases that we shared, 2 of them so far, I think, with the almost same kind of scenario. One of the patients that came into us had what we call it gastric and neuroendocrine tumor, which is a kind of a stomach cancer type of tumors or potential cancers in the stomach that can behave like a cancer if don't treat it. Those patients, it depends on the type. There's multiple types, but just to make it short, if they have been taking acid suppression medication for a long period of time, this can enhance that type of tumor. So once you diagnose it, if there is no absolute indication for the acid suppression medication, you need to stop that medication. So now they have reflux, which is an indication, and they have a gastric tumor that we just treated, and I don't want it to grow up again. So I need to stop that medication for them. They are young or they are old, doesn't matter, right? If I tell you if you take that medication, it will enhance the tumor that you had and it might grow up again and you'll have a new one. You want any option that you have available to stop that medication. So we got a couple of patients, young, female patients, and we just got them in the schedule on no time. Got to see the oncologist, the crochet, got their treatment plan, got their tumor cleared, got the workup done, so the Hope, got their surgery, and they're back to their life. And they don't have, hopefully, they don't need to get to the PPI again or the acid suppression medication. So that's a kind of a extreme indication, but I've seen
it's happened a couple. It's interesting. I mean, one thing I will say to your question earlier is that I don't know that you want someone to take an unnuanced approach to this problem, despite it seeming so commonplace, because historically that was something that was done where you came in, you saw a surgeon, you had a hiatal hernia, you went to surgery, a week or two later, right? And that's when you could do the wrong operation because you didn't have the right diagnosis. So then you not only help the patient, but you potentially make things worse. And I think that a thoughtful and nuanced approach whereby we are dogged about getting to the root of the issue and getting a proper diagnosis, because we don't want our reputation to be ruined by having a bunch of poor outcomes. We want to help patients at our core. That's our most important driving factor. And if we don't do all this workup, all these studies, none of it's superfluous. We don't want to do anything that you don't need to do or waste your time, and we want to be respectful of the patient's time and also our time. We want to just make sure we're efficient and good stewards of the ancillary services that's necessary. So we only do what's necessary so that we can guarantee that when we have an intervention or that when we recommend an intervention, it is going to be the best thing for that patient.
Well, and that's great to hear. Every time I talk to you guys, I'm always left with that impression that there is a genuine caring that happens when everybody comes in to see you guys. Nobody is rushed through any of this, even though there's a lot of people going through this, right? Yeah. But you guys are doing such a fantastic job of just making sure everybody's taken care of. Before I wrap this up, I've been seeing, this is funny that you guys came in to talk to me today, but I'm on TikTok way more than I should be. I'll admit that. But I have been seeing now a lot of these talks about, specifically, because I mentioned earlier, omeprazole. How do you guys feel about that medication? Are there any medications for this kind of condition that you would say, look, maybe don't do and make sure you go see a doctor?
No, PPI, again, it's one of those, most commonly, it's safe enough, it's over the counter.
Right.
Just put it this way. And it's one of the most common prescribed medication. And it is a really good medication to help with the acid suppression medication. The usual advice that I give any patient that I have is, one, do you need the medication or not? If you truly need the medication, then you need the medication. Two, what is the lowest effective dose that should I put you on it? All of them, they work the same. I switch between 1 and 2 type just because the mechanism of metabolism, and that's it. Oh. So do they have side effect? Yes. Tylenol can cause liver failure, but we take Tylenol because it is a safe medication. Acid suppression medication, they try to link it to so many other things, but I would tell you the things that we know that it is somehow is linked or associated with it is, increased risk of fractures, increased risk of certain, infection like C. diff infection early on when you take it, or increased risk of pneumonia when you take it in the first 30 days. Rarely small bacterial overgrowth or malabsorption of certain vitamins and not vitamins, minerals. Again, there is some link between those kind of things. But overall, the safety profile of this medication, if it's taken properly for the right diagnosis and the lowest effective dose, is tolerable.
Is there social media things you guys see that it just drives you crazy in your profession? That the advice people give where you're like, please stop.
I try it. It inflames me too much. I think I try to avoid it mostly. I don't know that you're on social media yourself.
I don't follow
that's
social
probably
media
for the best.
But I see patients comes in and say like,
well, that's just it. They have to come in and be like, well, no, I saw on this thing.
Yeah. And I always tell them like, one, my job here is to protect you and educate you. if you want to hear my advice, be my guest. If you don't, I can give you the data where you can look for if you are someone who want to dig deep and read. And I just can't orient you to the right place to read.
Right.
You can't change people's minds.
No, that's true.
Your
That's
job
so
is
true.
to help them out, not to judge them. I don't judge them,
Yeah.
Some people look for Google, some people look for, search engines, other kind of search engines, TikTok, social media. I tell them, just if you are someone who is a really reader or kind of someone you believe on all of these conspiracies and, just look for the right place to find the information. And I'm more than happy to guide you do that. But
those are my favorite patients, the ones that are very well informed, or they just are interested and they want to learn more, and they come in with an open mind. But because we're both GERD nerds, so we just absolutely
GERD nerds. I'm going to have a band called that, if that's all right.
Hashtag GERD nerd. You heard it here first.
Well, the nerd is actually the non-erosive reflux disease called NERD.
Oh, that's a thing. Oh, that's a thing.
GERD and NERD is actually GERD is
God, that works on so many levels. I love it.
Yeah, absolutely. We should get some shirts made. Actually.
You guys should.
Yeah.
Dr. Pial Hope and Dr. Ali Zakaria from Monument Health, thank you guys again for coming in and talking about this. And I can't stress enough to people the teams that they put together at Monument, and knowing that you two guys work so close should give everybody a lot of comfort when it comes to a situation like this. Do not hesitate. Start with your family doctor, and then let them lead right to you guys if it gets to that
I think
point.
I personally, and I trust Dr. Hope because he does the exact same thing, will never push a patient to come and do a procedure. We just offer you the procedure.
Right.
You will not hear from me or him that, you got to do this procedure, otherwise you're not going to be fine. No, that's not going to come out of our mouth.
We just educate and empower patients.
And we actually offer so many other options in the same visit that your alternative is this, and there's so many alternatives. So when we advise you, this is good for you because of your medical status. Maybe you're not a good candidate for CTF because you have this and this and this. You better get this procedure because that's going to fit you better than this. So presenting CTF is just one option of reflux management, but that doesn't mean that you can just walk in the door and say that I am here for the CTF. Doesn't mean that you're going to get it.
Thank you guys again very much. Dr. Hope, Dr. Zakaria, love talking with you. Come in anytime, all right?
Absolutely. Thank you.